Hi, and welcome to this short course on fracture repair in our street dog populations. My name's Ian Patterson, and I've practiced as a vet in the UK since 1989 with a special interest and further qualifications in soft tissue and orthopaedic surgery. We will talk mainly today about fracture repair in dogs, but many of the principles will apply to cats as well. The talk will revolve around my own experiences of treating fractures in practice, but with a particular focus on how some of these skills can be applied realistically in situations where we lack the facilities of a fully equipped vet hospital and our patients are often dogs that live on the streets. Right at the outset, I'm going to say that many of the fractures you see day to day will have no other option but limb amputation as the preferred treatment, and this will very often be the quickest and most humane method of repair to get the dog out of pain and back to living a good quality of life as soon as possible. As we all know, dogs adapt fantastically well to managing on three limbs. A lot of these fractures that you see will be several days old. They will be infected, infested with maggots, or associated with other injuries such as severe soft tissue trauma or nerve damage. In all of these patients, amputation of the limb is most likely to be the only sensible surgical option open to us. There are, however, cases that present to us where we have an excellent chance of saving the leg rather than going straight to amputation. Although amputation is very often necessary, it should still be considered the last surgical option, since if an amputee then fractures one of its remaining limbs, it's in real trouble. Fracture repair in street dogs, where funds and access to equipment can be limited, does make things more challenging, but not impossible. This is a picture of a young street dog, and on the right here you can see it has suffered a fracture of its distal femur. This is something that we can repair without too much difficulty, assuming the fracture isn't more than 3 to 4 days old. I'm going to discuss today the sorts of fractures that I think are open to reconstruction and repair with minimal equipment but a sound knowledge of the principles involved. And by minimal equipment, I mean intermedullary pins, arthrodesis wires, orthopaedic cerclage wire, and rudimentary external fixators. We won't be discussing the use of bone plates, intermedullary nails, or more complex external fixation techniques, since these all require a large amount of specialist support equipment. Apart from the various implants, a surgical kit, and a few specific orthopaedic instruments, the only tool you will need is a variable speed drill, and I'll go into this later. There are two very important clinic features that you will need to have in order to be able to undertake surgical fracture repairs. One is access to an X-ray machine, and the other is clean kenneling facilities. Without being able to take at least two orthogonal X-rays, that is, two X-rays from right angles to each other, craniocaudal and mediolateral usually, then fracture planning and implant selection is impossible. If you're in any doubt about what you're looking at, X-ray the contralateral limb, that is the other limb, for comparison. For example, is it a tibial tuberosity avulsion fracture, or is it the normal physis in a growing pup? Preoperative X-rays are essential. Immediate post-op X-rays are ideal, and post-op X-rays to confirm healing before implant removal or a return to the streets is preferred. In reality, all three of these should be considered essential, but I'm well aware that we might be working in compromised situations. If you've got your own X-ray machine, then it makes life a lot easier. It may be that you have access to X-ray facilities, but not on your own premises, in which case good preoperative X-rays are essential, since post-op X-rays will not be available to you. This is a case of a young dog with a tibial tuberosity avulsion fracture seen here on the right, where the contralateral limb was X-rayed for comparison. You can see quite clearly that the tuberosity on the right has moved slightly further away from the tibia than the one in the normal limb. This is something that would probably need to be addressed surgically reasonably quickly, and we'll go into that later. In this case, an adult cat presented with a 10 out of 10 left hind limb lameness with palpable tibial instability. The mediolateral view here shows an almost normal looking tibia, whereas the oblique view illustrates a very obvious fracture, tibial fracture. This illustrates the importance of always taking at least two orthogonal views of fracture cases. Clean kennelling facilities are very important too, since these patients will require to be strictly rested post-operatively until the fracture is healed and any implants are removed. If the dog belongs to a responsible owner who can keep their pet indoors under observation, then discharge with post-op checks is fine. If, however, the dog is a street dog, then it should really be kept at the clinic or rescue facility until healing has occurred. I don't think it's a good idea to return a dog to street life with metal implants in its leg and an unhealed fracture. Orthopaedic surgery, including fracture repair, can be demanding and unforgiving, and the consequences of failure can often lead to limb amputation. We will maximise our chances of success if we pay careful attention to several important factors, which we'll discuss here in a little more depth. Patient triage and stabilisation, fluid therapy, antibiotic use, analgesia, patient selection, asepsis, which includes the surgical preparation of the patient, the surgeon and the operating area, surgical technique, and post-operative care. Patient triage and stabilisation. A fractured leg itself is unlikely to be a life-threatening injury, but there may be other significant trauma that is, especially since many of these cases present to us after road traffic accidents. Patient triage simply means prioritising the animal's different injuries in an appropriate order. It's vital that we don't zoom straight in on the obvious dangling leg, but instead take a step back and look at the whole patient. We've got to deal with critical life-threatening injuries prior to focusing on the fractured limb, and to that end we follow the classic ABC of airway, breathing, circulation. Ensure there is a patent airway and the animal can breathe sufficiently, and stem any significant hemorrhage using whatever means possible, direct pressure, ligature hemostasis, etc. Just because an animal is a patent airway doesn't mean it can breathe properly. Consider a case with pneumothorax or hemothorax, or possibly a case with multiple fractured ribs. In a nervous or aggressive animal, it might be necessary to sedate or even anaesthetize to address these concerns, and I will talk about the drugs we would use for this in a minute. Our immediate priority here is to save life. Significant life-threatening injury that can accompany a fractured limb could include spinal injuries, thoracic trauma, such as pneumothorax or thoracic hemorrhage, and severe head trauma. In all of these instances, the fractured leg is not our primary concern. This case was a Springer Spaniel that presented with ongoing significant hemorrhage from its cephalic vein. Obviously, we need to deal with this before considering how to repair any fractures present. In this case, we used artery forceps to clamp the bleeding vessel. Here we have a cat immediately after a road traffic accident who is having difficulties breathing. General anaesthesia was necessary to examine this patient, and its airways were confirmed to be open and clear. X-rays of its chest show why this individual was struggling to breathe. There's a loss of the diaphragmatic line and the presence of abdominal contents within the thoracic cavity. This cat had suffered a diaphragmatic hernia. Again, in a situation like this, a fractured femur is not our main concern. This dog presented to a clinic in Tanzania, and on X-ray we can see an obvious fracture dislocation of L5-6. Regardless of any long bone fracture present, this is the injury that requires to be assessed and prioritised in this patient. Unfortunately, the severity of the damage to the spinal cord was so severe that it was not appropriate to perform any other surgery here. Once we've addressed any obvious life-threatening injuries, we need to consider stabilising our patient and dealing with any open fractures, and the first protocol is to establish venous access with an IV catheter, preferably 2. The obvious choices are the cephalic veins in the forelimbs, but if these prove difficult to access, then the lateral or even medial saphenous veins in the hind limb are good alternatives. As mentioned before, we may need to sedate our patient in order to be able to stabilise them effectively. The drugs used will very much depend on where you are working and what is available to hand. Obviously, some drugs have advantages over others in various circumstances, but ultimately we have to use what we have to the best of our abilities. I would, for example, avoid ACP and alpha-2 agonists such as dexmedetomidine, medetomidine and xylazine in animals with cardiovascular or circulatory compromise, and instead opt for a more cardiostable combination of a benzodiazepine, such as diazepam or midazolam, combined with an opiate such as methadone or buprenorphine. If full anesthesia is required, then IV propofol or alfaxolone are excellent with gaseous anesthesia for maintenance, although in your clinic situations, total intravenous anesthesia using ketamine and diazepam is also very valuable. In cats, a reasonably safe combination to use in a trauma case would be ketamine combined with midazolam. Open fractures should be treated as an emergency once the patient is stabilised. A fresh open fracture is classified as a contaminated wound, but will become an infected wound within a matter of hours due to the presence of bacteria. Apply a water-soluble sterile gel such as KY jelly to the wound before using clean clipper blades to clip away fur around the area. Never handle the tissues with bare hands due to the risk of introducing additional bacteria to the already compromised wound. Remove any obvious foreign material such as grit, plant matter, old sutures, etc., and cut back any obviously dead tissue with sterile, sharp scissors. Try to do all of this in as clean an environment as possible. Use an isotonic solution such as Hartmann's or 0.9% saline to copiously lavage the wound. Isotonic solutions are non-toxic to cells, which is why they are preferred. If you don't have access to bags of Hartmann's or saline, then use large amounts of bottled drinking water to lavage the wound. I've also seen myself putting a severely contaminated wound under a running tap in order to try and remove the debris, although this required the dog to be heavily sedated first. Again, it's a case of using what you have available to you in the compromised working conditions that you might find yourself in. There have been several studies on the ideal pressure to lavage tissue, and the current understanding is that it can be approximated by using an 18 gauge needle with a 20 ml syringe. As in the photographs here, sterility of the procedure can be increased by attaching the syringe to the end of a drip line using a 3-way tap, and this means you don't have to keep inserting the needle into the fluid bag to draw more fluid up. You could also just attach an 18 gauge needle directly to the end of the drip line and squeeze the bag. The aim is to keep a steady flow across the wound site at an oblique angle. Work from the top of the wound down so that the contaminated fluid does not flow over the area you've already cleaned. As we've already discussed, many of us aren't working in hospital environments, so we need to be able to understand what the ideal approach is and then get as close to this as we can. After this initial triage procedure, assuming the patient is not going to be prepared for immediate surgery, then we must cover the wound with a sterile dressing to protect it against further contamination, trauma and infection. Wound dressings are a talk in themselves, so I'm only referring to the absolute basics here. The most commonly used primary layer would be the hydrophilic polyurethane foam ones that are non-adherent. These are great all-rounders and perfect for this purpose, and a good example would be Aleve. Fluid therapy. Many of these patients will be street dogs and already in a state of dehydration. Some may also be in hypovolemic shock. Starting IV fluid therapy without delay is crucial. Fluid therapy in itself is a vast topic which I won't be covering, but keeping things simple, I would always get these dogs onto either isotonic 0.9% saline or Hartmann's intravenously as soon as I have the catheter in place and secured. Use a fluid rate appropriate to the dehydration or shocked state of the animal. This isn't the place to get into fluid therapy other than to say there are some great apps out there now that will do all the calculations for you. Get one of these downloaded and make life easier for yourself and your patient. The Animal IV app that I've shown here from MillPledge is free, easy to use and contains a lot of additional information to help you with any fluid therapy queries you might have whilst on the move in a busy day. Make it practice to place an IV catheter into every trauma patient that you see as a matter of priority and make sure it is secured firmly in place. Fluid rates for crystalloids that I think you should always have memorised for immediate use are as written here for dogs. Maintenance rates 50 ml per kilo per day, which is equivalent of 2 ml per kg per hour. Surgical rate, it used to be 10 mils per kg per hour, but current thinking is 5 mils per kg per hour for healthy dogs. Dehydration, dogs that are 5 to 15% dehydrated will require 50 to 150 mils per kilogram body weight to replace their deficit, plus their ongoing maintenance requirements, and this can be replaced over 24 hours. Shock rates in fluid therapy. The shock bolus of fluids is based on the estimated blood volume of dogs, which is approximately 60 to 90 mils per kilogram body weight. This amount of fluid is typically not required because most patients have not lost their entire blood volume and will respond to lower volumes of fluids. Start by administering 10 to 20 mils per kilogram boluses of isotonic crystalloids over 15 to 30 minutes and then reassessing the patient's intravascular volume status after each bolus. And we do this by checking heart rate, capillary refill time, peripheral pulse quality, mucous membrane colour and consciousness. Subsequent boluses can be administered according to whether perfusion parameters have improved or not. Cats are typically less tolerant of fluid boluses than dogs, and so lower volumes are recommended, and we would use 10 to 15 mils per kilogram body weight. Other fluids that can be considered in the treatment of hypovolemic shock include hypertonic saline and colloids, but this is beyond the scope of today's talk. Antibiotics and antibiotic use. Administering an IV injection of a broad-spectrum antibiotic at the beginning of treatment and continued use for the appropriate timescale is also critical. Prophylactic antibiotics are warranted in any clean surgical procedure that will take over 90 minutes or any orthopedic procedures where we use implants and the consequences of infection are significant. I use either intravenous amoxicillin clavulanate or cephalosporin for this purpose and administer the first dose approximately 30 minutes before starting surgery. This usually coincides with the induction of anesthesia. I will repeat this dose every 90 minutes during prolonged surgeries. Open fractures where there's a break in skin will almost always be infected and so require immediate use of IV antibiotics on presentation to the clinic. Closed fractures, although not infected, will require prophylactic antibiotics at the time of anaesthetic induction for surgery. A lot of our patients will be undernourished dogs with other ongoing medical conditions, mange, bloodborne parasites, etc., which will render them more susceptible to immunosuppression and infection. So I feel that antibiotic use is justified in these cases, both during and for a short while after surgery. We are quite rightly being driven as a profession to be more careful about prescribing antibiotics to our patients, but when the consequences of an infected fracture repair may lead to amputation, we do need to strike a balance. Following orthopedic surgery, antibiotics can be continued for an appropriate timescale based upon the circumstances, but current recommendations are that they are not required for longer than 24 hours post-op in clean surgeries. For example, a closed fracture repair in a young, fit, healthy animal performed in a sterile manner and hospitalized in a clean environment may require only IV antibiotics at induction and during surgery. However, an older immunocompromised dog with an infected open fracture repaired in more basic facilities and recuperating in a rescue kennel, I would be keen to extend the course by means of oral medication for up to a week. Don't use antibiotics prophylactically on a patient with a closed fracture for days prior to surgery, since there will be an increased risk of bacterial resistance should the patient go on to develop a surgical site infection following the operation and having been exposed to the antibiotic in advance. A bacterially resistant surgical site infection is an orthopedic nightmare. Analgesia. Providing sufficient analgesia is critical, and intravenous analgesia might be all that is required in order for you to properly assess the patient at first presentation. The intravenous route allows the drugs to work immediately, and this goes for antibiotics, fluids, and any other medications for that matter. Giving a subcutaneous injection to a dehydrated or hypovolemic patient will result in a very poor uptake of that drug due to the subcutaneous tissues being poorly perfused. Again, As with antibiotics, the choice of analgesia will depend very much on what is available at your clinic, but usually a combination of different analgesics is preferable to using one single drug alone in order to achieve what we call a multimodal approach. Other methods of administration of analgesics could include IV infusions, epidural use, splash blocks, and local infiltration. We want to use analgesics pre, peri, and post-operatively. Drugs commonly used intravenously include the opiates such as morphine, methadone, buprenorphine, non-steroidals such as meloxicam, local anesthetic agents, for example lidocaine and bupivacaine, ketamine hydrochloride, and paracetamol. Alpha-2 agonists like medetomidine and xylazine can also be used IV, but I'd be very careful here due to the effects they can have on cardiac output. Analgesia can be maintained post-operatively using oral non-steroidals, tramadol, gabapentin, paracetamol, etc. There are various forms of local analgesia can also be employed at the time of surgery, including epidurals for hind limb surgeries, or infiltrative or splash blocks using either lidocaine or bupivacaine. Epidurals I've never done routinely, whereas splash blocks are easy to perform in the field and can make a significant difference to post-operative pain. My main concern with using epidural anesthesia for hind limb surgery is the prospect of a dog recovering from its general anesthetic and being unable to stand. It may injure itself when trying to get up. There's also the matter of feces soiling our surgical wounds until the epidural wears off. I think it's fine to perform epidurals, but you need to have constant nursing supervision in a clean environment to avoid complications on recovery. And drugs used typically in epidurals would be a morphine and bupivacaine combination or morphine and lidocaine. My standard analgesia approach to a fracture repair in the UK would be as follows, set out in the slide. I would use ACP, methadone, as my pre-medication, and I would give IV meloxicam at the time of induction or on recovery in a hypovolemic patient. Some people prefer to reserve meloxicam or non-steroidals for post-op use, since if you get a period of hypotension during surgery, then the renal autoregulatory mechanism doesn't work properly and the kidneys are at potential risk of NSAID injury. This is a small risk, but it's a risk nevertheless. I would use an IV ketamine and lidocaine infusion perioperatively, and also I would give methadone IV 4 to 6 hourly post-op for 24 hours. Oral meloxicam and oral tramadol post-op for 1 to 2 weeks. And I will often dispense gabapentin for oral use following limb amputation surgery or any other surgery that may increase the incidence of neuropathic pain, and that includes jaw and dental fractures. Cold compresses immediately post-op for 15 minutes may also provide some analgesia, but they're predominantly used to help reduce immediate post-op swelling. Ideally, they should be continued 3 to 4 times a day for a week, but in all reality, almost never gets done in our busy clinic. Wrap ice packs in towels and place around the operated limb, avoiding placing them directly over metal implants, such as plates that lie immediately beneath the skin. Avoid direct contact between the ice pack and the skin. Ice packing the leg post-op adds nothing to your time, since it will take 15 to 20 minutes to recover the patient from general anaesthesia anyway, so if you've got the facilities, it's well worth doing. Most importantly, use what you have access to, but please do use analgesics at the earliest opportunity when these patients present, and wherever possible use multiple analgesics from different drug classes in order to provide the most effective release from pain possible. I've never used fentanyl patches, but they are available. They need training in use, and remember they cannot be used in cats. Patient selection. All of this conversation about triage, the use of IV fluids, antibiotics and analgesics applies to each fracture patient that comes through the door of your clinic. At some point, once your patient is stable and you've taken some x-rays, you need to make the decision on whether to repair the fracture or amputate the limb. In many cases, the sensible answer will be to amputate the limb in order to get this dog recovered, mobile and pain-free as soon as possible. There are a population of dogs with fractures, however, where carrying out a fracture repair will be within the capabilities of your clinic and that will provide a better outcome for the patient in the long term. We have to remember that many of the dogs that you see will be street dogs, and although amputation may provide a quick and effective solution, if this patient then gets into another road traffic accident and fractures one or two of its remaining limbs, the prognosis is now very poor, regardless of what we do. So, the message is to amputate if this is truly in the patient's best interest, but to try to repair the fracture if you've got the facilities and the fracture lends itself to this approach. The whole basis of this talk is to discuss and explore the types of fractures that are repairable using implants that you hopefully can all access that are not going to break the bank. Every case needs to be assessed on its own merits, but the types of patients that lend themselves to successful basic fracture repair include young patients with their good healing potential, healthy patients that don't have any underlying diseases, infections or heavy parasite burdens, closed fractures, that is ones that are not open to the environment in any manner, recent fractures, fractures not involving joints, simple long bone fractures such as midshaft fractures of the tibia or humerus, growth plate fractures in young animals and avulsion fractures. Poor candidates for fracture repair would include old patients, patients with pre-existing diseases, and that could be parasite burdens, malnutrition, liver or kidney disease, neoplasia, concurrent infection, open infected fractures, old fractures, intra-articular fractures, and patients with other major traumas such as spine or pelvic injury or cranial traumas. Asepsis, surgical preparation of the patient, surgeon and operating space. Absolutely critical to the success of any orthopaedic procedure is the knowledge of how to reduce the risk of surgical site infection in our patients. SSIs, or surgical site infections, can arise from many stages of the procedure, not just the surgery itself, and it can't be overemphasized the importance of knowing how these arise and how to reduce the risk of developing them. If a patient is hospitalized with an open fracture, they could acquire an SSI prior to going to surgery if the wound is not protected and treated appropriately. SSIs can also result from poor aftercare of the surgical wound. So even if you perform fantastic orthopaedic surgery, if you don't make sure that the wound is protected afterwards until it is healed, then you may still get an SSI. In theory, an SSI occurs within 30 days of surgery, but in orthopaedics we extend this to 1 year if implants are used. This latter point illustrates how important it is to minimise the risks, since many of our patients will be back out on the streets once the fracture is healed. So if they develop an SSI 6 months later associated with an implant, we will never know. We'll discuss briefly preparation of the patient, theatre and vet for surgery, and then talk about how we can minimise the risk of SSIs during the surgical procedure itself. And remember that an SSI is something that the animal doesn't come into us with. It's something that it acquires whilst in our care. Do not fall into the trap of thinking that antibiotic use will prevent surgical site infections. The use of antibiotics is not an alternative to having an excellent aseptic approach and meticulous approach to tissue handling. If you only take 1 point home from this talk, then I promise you that the one that will make the biggest difference to these patients and your chances of success is to have strict protocols in place regarding an aseptic approach to fracture repair. In fact, to all surgery. Surgical preparation of the patient. After anaesthesia, the first task is to perform a good surgical clip of all fur. Keep clipper blades clean and sharp, since this will reduce microtrauma to the skin and the increased risk of bacterial infection that this brings. Make sure your surgical clip is extensive, since you might need to extend your surgical incision during the operation. For surgeries of the femur, I clip from the midline spine and ventrum circumferentially around the limb to well below the stifle. I will then wrap the hair-covered foot and lower limb in bandage during surgical preparation before moving to theatre, where I'll apply a sterile covering over this bandage. I tie the limb up during surgical preparation since this makes it easier to clip and clean and also helps provide some traction to the fracture, which will help in its reduction at the time of surgery. For the tibia, I will clip from the proximal or mid-femur area all the way to the distal metatarsal area and use bandages as above. Forelimb fractures, I will clip similarly. Once clipped, the skin is surgically scrubbed using either chlorhexidine or povidone iodine. I prefer chlorhexidine because it's not inactivated by organic material, and it's also not likely to trigger the urticarial skin reaction some dogs have with povidone iodine. It's also got a longer residual action. Having said that, both are very effective and use what you have access to. The important thing to remember here is that both of these agents work on contact time, with 5 minutes a good guide. It has been shown that povidone iodine requires a longer contact time than chlorhexidine for full effect, which is another reason I opt for chlorhexidine. There is no such thing as a quick surgical scrub. A final solution of alcohol is then applied before draping the leg. Wearing gloves while scrubbing further reduces the risk of bacterial transmission from the assistant's hands to the patient. Drapes should cover as large an area of the patient as possible, including the table. We don't want exposed table or fur anywhere near our surgical site. It's most likely you will be using reusable autoclavable cloth drapes. These are what I use, but I also place a waterproof disposable drape beneath them, since once cloth drapes are wet with blood or saline, they're considered non-sterile. If cheap waterproof disposable drapes aren't available, then if a cloth drape becomes wet, apply a fresh cloth drape on top of it. Don't remove the wet one, just put another one on top. Fix drape with towel clamps. I also use adhesive iodine impregnated drapes as a final layer, which are great if they're available. They protect the open surgical wound from potential contamination from the skin immediately next to the surgical site. Instrument trolley drapes are usually cloth, but again, if you've got access to disposable waterproof paper ones, they are better in order to prevent strike through. If not, then double drape the trolley with cloth drapes. Surgical preparation of the vet. This will depend on what is available to each of us, but again, the emphasis is on doing everything possible to reduce the risk of SSIs. Wear a cap to cover hair and a surgical mask always. Use clean scrubs that are reserved for the surgery and not the clothes you've been working in that day. Disposable sterile surgical gowns may be a luxury, but if you do have access, then they are great. A cheaper alternative is simple cloth operating gowns that can be worn over scrubs and sterilised for each use. Remove all jewellery before scrubbing up and follow standard scrubbing protocols using either chlorhexidine or povidone iodine. The first scrub of the day is the most important, and I spend at least 5 minutes doing this. You can get reusable autoclavable nail brushes, which, if available, provide another step in reducing the risk of SSIs. If you don't have access to these, then use a new scrub brush for each orthopaedic procedure. There are some new alcohol-based scrub solutions, which are a little quicker to use. I use chlorhexidine, but if you react to this, then povidone iodine is fine. Once scrubbed and your gown is on, if you've got one, then put on your surgical gloves, usually latex, but obviously not if you're allergic. And you can put your gloves on using either an open or closed gloving method. Personally, I've always used the open method. If you do happen to puncture a glove during surgery, then ideally you should change gloves, although I must admit I often don't discover small puncture wounds until after the surgery when I remove my gloves. Anecdotally for me, this doesn't affect my outcomes, but this is possibly because we're incredibly strict with patient prep and scrubbing up before surgery. I think if you do notice a break in the glove and you're working in a compromised environment, then I would definitely put a fresh pair of gloves on. Surgical preparation of the theatre. When I say theatre here, I mean room. As having worked in various situations, I am well aware that many of us working do not have the luxury of a sterile operating theatre. The image on the left here is obviously an ideal situation, with the room itself being used only for sterile surgeries and nothing else. And this is a situation in which very few of us will find ourselves in. The two images on the right, top and bottom here, are from a clinic in Tanzania. There's no reason at all that aseptic preparation of the patient and surgeon in both scenarios shouldn't be on an equal, and if the rooms on the right are cleaned thoroughly and regularly, then we minimise the risks of infection. There are simple things that can be done regarding our operating space to dramatically reduce the risk of incurring SSIs during surgery, a few of which I'll mention just now. First of all, restrict the operating area to people who need to be there and make sure they wear masks, caps and clean clothing during procedures. There is a direct link between the number of people present in the operating room and the risk of developing an SSI. Because a fracture repair is interesting surgery, don't allow a crowd to stand around watching. Keep doors and windows closed during procedures. Difficult in the temperatures you may be working in, I understand, but when undertaking orthopaedic surgery it really is important. You can see here that the window is open. This is not an orthopaedic procedure that's been carried out. Clean walls and floors thoroughly after each procedure if cross-contamination occurs, and also at the end of each day. Clean operating tables, instrument trolleys, etc. thoroughly on a daily basis. I know that this is all not necessarily possible depending on your situation, but I can't stress how important the connection between cleanliness of the environment, asepsis of the surgeon and patient, and the reduction in developing SSIs is. Surgical technique. So we've triaged our patient, we've stabilised them, we've got analgesics and antibiotics on board, and IV fluid therapy is ongoing. Our assistants have clipped and scrubbed the limb and it's all draped and ready to go in our clean room. We're gloved and we're ready for action. So can we now talk about bones and fractures? Well, not quite. Our surgical technique is the final matter we need to address if we're to expect success when repairing fractures. Poor surgical technique will not only reduce our chances of a successful outcome, but they'll also increase the risk of developing SSIs, surgical site infections. The most important and valuable guide is always to refer back to Halstead's principles, which I have outlined here, the 7 principles. This is something which I do on a daily basis, and it's constantly on my mind during any surgical procedure. Of all of the charts and tables and graphs that you're exposed to throughout your life as a vet, this list is the most valuable to you as a surgeon. Excessively prolonged surgical times are detrimental. The risk of developing infection doubles with each hour of operating time, and prolonged anaesthetic times, they also increase the risk of infection due to the negative effects on the immune system. These are particularly important statistics with fracture repair surgery, since these operations tend to be longer surgeries than most. Having the right tools for the job will make a massive difference both to the patient and your enjoyment of the surgery, and allow you to adhere to Halstead's principles. Olsen-Hager needle holders here on the left are to me the best. They save you having to put an instrument down and pick up scissors every time you want to cut a suture. Scissors need to be sharp, otherwise they will crush the tissue and cause further damage, which may impede or delay healing. But try to do any cutting using your scalpel blade. Post-operative care. This is the final topic to consider in the overall picture before we get into the specifics of fractured bones and how to repair them. Our surgical wound itself is a weak point, particularly in the first 12 hours post-operatively before an effective fibrin seal can form. During this time, the wound is prone to infection from a number of sources: being licked, coming in contact with dirty flooring or bedding, being handled directly by one of us, or the patient being placed with the wound in direct contact with the floor after surgery. It's vitally important that on completion of surgery the wound is either covered with a sterile adhesive dressing, such as Primapore, which you can see here, or at the very least the patient is placed in a clean kennel for recovery. If post-op x-rays are to be taken, make sure the x-ray plate is clean, since this is a potential source of infection for the freshly closed surgical wound. Finally, take all measures to prevent the patient getting to its wound by using buster collars, inflatable collars, bodysuits, old t-shirts, shorts, whatever it takes.